Good morning, good afternoon, and good evening to all our viewers who have joined in the YouTube channel for the urology exam preparation. Today, we are going to discuss the various scenarios possible in Uro Radiology examination table. As we know, uroradiology is not a very extensive subject. We can start from ultrasound, CT scans, MRI scans, and nuclear scans. That completes the uroradiology almost. There are some other specific scans like retrograde ureterogram and retrograde ureterogram like bulb ureterogram, which we do intraoperatively, which could be covered in various clinical scenarios itself. So in general, we will have only this predominant four groups of radiology sections, and in the same table the usual another scenario will be in urotechnology. As you all know, urotechnology is a big C, and that will be covered on a different day. Now we have a trainee who has volunteered to take part in this discussion. Welcome, and
Hi, welcome, Mr. D.
thank you for coming, and thank you for agreeing to recording so that it's available for others.
Thank you very much for arranging this, and I'm happy for that to be recorded for the purpose of the exam. And thank you very much.
Thank you very much. I'm just going to start the timer now. We will do exact 10 minutes as per the exam pattern. Okay?
Sure.
Good. You have a 72-year-old gentleman who was referred from GP due to increased PSA at 6.2. Otherwise, he's quite fit. How are you going to treat him?
So I will see this patient in one of my prostate cancer clinic in 2 weeks pathway referral. So this patient ideally should have a urine dipstick on arrival, international prostate symptom scores, and SHIM score as well. So I will see that patient and discuss with him why his PSA was done in the first place, and that was associated with low impact symptoms. And then I'll ask him about specifically according to the IPSS score about his low impact symptoms, and if he has a family history of prostate cancer. And of course, I will know if his background is he from Afro-Caribbean background as well. I'll ask him about his general condition, performance status, and if he has taken any medication at the moment, including anticoagulation. I'll ask him about any previous surgery and any previous allergy as well. This patient, followed by that, I'll examine the patient, chaperone exam, starting from general examination, moving to focus urological exam, abdominal exam, and palpating the bladder, inguinal scrotal exam, looking at the testicles and the penis, followed by digital examination to ascertain the prostate size, and if there is any abnormality on the prostate, and also S3. I would ask the patient as well if he has any stigmata of weight loss as well.
Okay, so we will just proceed faster, being a uroradiology table. He has no urinary symptoms, examination is normal,
Okay.
his prostate measures 60 cc, no specific sinister signs noted, he has no medical comorbidities. So how are you going to further treat him for his increased PSA?
Given that his PSA is above the reference data, and I think his PSA density is around 10, I will cancel him to have an upfront MRI scan to further outline his prostate before discussing any possible prostate biopsy. So I will ask him to have a multiparametric MRI scan.
Okay. Is there any role for repeating the PSA?
Yes, I would do that because he has a single PSA, and there is always a chance that his PSA was falsely elevated, and that's due to either sexual intercourse or masturbation or UTI around the test. So in the clinic, I repeat his PSA first, make sure it's still high above the reference, and if that's the case, I'll request an MRI scan for him.
Okay, his repeat PSA is 7.8, not much change, and he's going for MRI scan. Why do you select MRI scan for evaluation of increased PSA?
Because that's the NICE guideline now that any patient with curative intent or likely to have a radical treatment for prostate, it's advisable to have an MRI scan up front of them. And that's proved with the PROMISE trial that showed that MRI scan increases the sensitivity of the if associated with prostate cancer, and showed as well that if someone had an MRI scan up front, 1 in 4 could have avoided biopsy. And MRI scan has a very high negative predictive value around 90%. So that's why it will help target the biopsy afterwards. And MRI scan can give us a clue as well if there is any lymph node can be spotted on the pelvis as well, and gives us a local staging about if it's localized inside the prostate or likely to have reached the capsule as well.
Okay, very good. How will you explain the MRI to him?
So MRI scan is one of the magnetic scans. So it relies on the principle of the proton inside the hydrogen ion cell. When it's being exposed to magnetic field, it's being aligned longitudinally. After that, if there is a radio frequency application, the hydrogen, the proton is being realigned in a transverse plane, and once that radio frequency application has been removed, there is a phase 1, which is T1. There is a relaxation, which releases energy to the surroundings. There is a coil in a MRI scan which picks up that energy and transform it into an image. Then there is a late phase, which is T2 phase, which is a decay phase. And the amount of energy is being released to the surrounding tissue. That's being picked up by the coil as well, and that gives an idea about any abnormal area, anatomy and abnormal area inside the prostate. These are the anatomical sequences. The other sequences, which is the functional one, diffusion weight imaging, dynamic contrast enhancement, and ADC, these are added up to increase the sensitivity and specificity of the MRI scan. It's being done at a day case, not day case, it's being done as a few hours investigation, and usually we get the result 10 to 2 weeks after, depends on the hospital and protocol. Then we'll call him back after the MRI scan for discussion of the next treatment.
Okay, so what are all the types of scans attempts in the multi-parametric MRI? So multi-parametric means it's like T1, T2, what other things?
So T1 is the initial phase, and that's very helpful for the anatomy. And usually the fat is bright because it loses energy faster than water. Water is dark. And T2 is the decay phase. And if there is abnormality in the peripheral area in terms of prostatic cancer that appears of low signal intensity compared to the other peripheral area, then after that there is a there is diffusion weight imaging sequence. And that sequence it depends on the Brownian movement of the water. If there is a heavily or densely packed cell, there is a restricted diffusion of the Brownian movement of the water, and it appears bright. And that corresponds with an area of normality, such as prostate cancer. The other differential would be abscess area of edema and pus. That's diffusion weight imaging. And after that, there is dynamic contrast enhancement after infusing or giving the gadolinium contrast. The prostate cancer cell, they have a newly formed blood vessels by angiogenesis, and that they're quite immature, so they pick up the contrast and they release it quite quickly, and that's defined as a rapid wash in, wash out. Usually the prostate cancer area appears white on that phase. Then the last one would be the ADC, which apparent dynamic coefficient. It's a calculated value using the DWI phase, and it gives a value, and prostate cancer appears dark on that phase.
Okay, so with these phases, how are you going to evaluate his risk? What criteria you have?
So radiologists, they use a system called Spirate system, which stands for Prostate Imaging Reporting and Data System. And depends on the likelihood of clinically significant cancer, they give it a score. The lesion, it's given a score. Score 1, it starts from score 1 to 5. Score 1 is highly unlikely to be significant prostate cancer. Score 2 is unlikely to be a significant prostate cancer. Score 3 is equivocal. Score 4 is highly, it's likely to be significant prostate cancer. While score 5 is extremely highly to be prostate cancer.
Okay. Are you able to see this picture now?
Yes, I can see.
Can you run it through for me?
That looks like an MRI scan of the pelvis and prostate axial section, and that looks a diffusion weight imaging scan. I can see the peripheral zone. It's of high signal intensity. There is heterogeneity in the transitional zone. On the right-hand side of the prostate anterior zone, there is a focus area of increased signal intensity. Yeah, that's marked by the arrow there, and that's correspondence was with highly suspicious prostate cancer. It could be Likert, it could be Pirates 4. Yeah, that's the ATC image of the prostate cancer. The picture is not great, but I can see there is an area of darkness among the prostate itself, and that's consistent with a prostate cancer as well.
Okay, we'll stop there. 10 minutes gone now. Okay, well done. And you may be quite surprised, the 10 minutes really flies. And my view is always have that background, what can I say, like a impetus that this is a Uro Radiology or Uro Technology table, and your markings will entirely depend upon how much of radiology and technology stuff you pour in. Okay, so you've done good marks, good standard. You really rushed through the initial evaluation, didn't wasted much time, but don't miss the very important things. For example, don't jump on to do MRI with just one PSA level. So keep the very key clinical things. I'm just taking this prostate cancer as an example. You may be using the same thing for any other uroradiology also. Key examination and making a decision based upon the PSA is important. And I can say you can be little bit more faster in explaining the T1 and T2 phases. It's a very important question, but the actual question what I asked you is, how will you explain the MRI scan to a patient? Say for example, this MRI scan could be quite claustrophobic. Patient should be laying still for at least 40 minutes, and it will be like a tube, and he may be having quite a noisy environment. He may be given a headphone with the music, or at least to dampen the external noise. Those are all the patient related information which you're going to explain to the patient. That's what I was expecting you to say for the question, how will you explain the MRI to the patient? Of course, once you explain this, the next question will be, what is T1, what is T2, which you started telling when you are explaining to the patient also. That is fair enough. MRI is very standard investigation for prostate cancer. So T1, T2, diffusion weighted image, and ADC should be very clearly understood, at least by definition wise. I think you did well. I can't find any issues in that, except maybe you can make the answers a bit crisp so that you may have more time to go through the images. Okay?
Yeah, thank you very much. Yeah, thank you.
Yeah, you have any questions before we go with the next one?
That's fine, but I was in two minds to expand or to try to abbreviate everything, shorten everything, because I know that's a technology station. So maybe I expanded a little bit in the explanation of MRI scan. I should have made a bit shorter than this. Yeah, that's fine. So yeah.
It just comes with practice, because these are all like open book exams. What is PIRAT score? How will you evaluate a patient based upon the PIRAT score? So what is PIRAT 1? Almost non-existent now. PIRAT 2, 3, 4, 5, which is almost a cancer in that. What is the percentages for each category? And these 5 parameters which you can use to take the prostate MRI. So these are all like open book exams. These questions are definitely going to be asked, and you will come across, even if not in Uro Radiology, you will be discussing it in the prostate cancer table also. So be very strong in that. Your answers are correct, but the words should be practiced so that you can finish that within, say, 60 seconds, 50 seconds, so that you have more time to go through. Okay?
Yeah, sure. Thank you very much.
Good, very good. You can log off if you want. I will send you the recordings anyway, as you know. Okay?
Okay, thank you much.
Good. Welcome. We got another trainee. Thank you, Kumar, for joining.
Good afternoon, Mr. Dhanasekaran.
Good afternoon.
Thank you for having me.
Good. So as you know, these sessions will be recorded and later available in the YouTube link, and I will send you a link also
Yes.
to revise. Are you happy to start the scenario?
Yes, Mr. Dhanasekaran, I have to start.
Very good. You have a 21-year-old gentleman presented to A&E with acute onset of left-sided scrotal pain. How are you going to evaluate?
I will review this patient urgently myself in the A&E. I'll initially evaluate the patient subjectively and objectively. I'll check his vitals and see if he's not septic. Then I'll proceed to examining his. I would take a focused history first, wherein I'll ask for the duration of pain. I'll look for any association of fever or any suprapubic or flank pain. I'll also look for other systemic symptoms, including vomiting. Then I'll proceed to a chaperoned examination after consenting him, where I'll check his vitals and see if he needs any resuscitation. If he needs that, I'll proceed as per ATLS protocol. And if not, I will go ahead with the examination, wherein I'll examine his. Once I've completed the general examination, I'll proceed to examining his genitalia. I'll look at the right testis first. I'll look for cremastic reflexes on either side. I'll look at the skin changes. I'll look at the position of the testis, if it is high riding or if it is if there's horizontal lie. And then I'll look for tenderness and temperature of the tenderness of the testis on the left side. Once I have done this, then depending upon the findings, I can come to a conclusion, and then I can decide if I need to take this patient straight to theater, or I can consider some form of imaging for him.
Okay, patient is quite symptomatic on the left side. He's almost refusing you to examine. Right side, you are able to feel the testis well. The left testis is little bit absence of cremastic reflex, and is also high riding. And what is your working diagnosis? Is there any investigation you can do?
So at this stage, my working diagnosis would be either torsion of the left-sided testis or left epidermolysis. I would have already done a urine dip by now, and if that is negative, then it is quite likely that this patient has torsion of testis, and I would offer him exploration of the left side plus or minus the right side, and I would not offer him any imaging at the moment.
Okay. His urine dipstick showed 1+ bacteria due to nitrates, and also 2+ leukocytes, otherwise normal. What will you do?
So in this case, I would definitely consider epidermolysis as a form of diagnosis, and especially if the duration of pain is more than 24 hours, and he has some urinary symptoms along with his scrotal pain, then I would consider a possibility of left epidermolysis. I'll start him on antibiotics as per my trust guidelines. In my trust, we would give him comoxicillin and gentamicin stat doses. This will be followed by an ultrasound of the testicle of the scrotum. As soon as I can arrange it, and I'll request a grayscale and a Doppler ultrasound for him for the scrotum. If there's nothing contributory on the abdominal examination, I won't be doing a KUB ultrasound.
Okay, you can see the scan pictures now. What is the role for ultrasound?
So an ultrasound is an examination of is a radiological investigation for the testis, which utilizes electromagnetic waves in the wavelength of 3 to 20 megahertz. In the testis, it can provide excellent, good quality, very good quality images, which can tell us about the presence of any tumors in the testis. They can tell us, a Doppler ultrasound can tell us about whether the blood flow is present in the testis. If there's a difference in the size, then it can tell us whether there's any atrophy in the testis. So these are some of the common indications for and uses of ultrasound in the testis.
So how the ultrasound works?
So ultrasound works by use of electromagnetic waves in the wavelength of 3 to 20 megahertz. The transducer produces these electromagnetic waves, and it goes through a gel, which then goes through the skin and other bodily structures. Now, depending upon the impedance of the different bodily structures, these waves get reflected back and are picked up by the ultrasound probe. And this is how it creates an anatomical image on the screen, which is visualized as a grayscale ultrasound.
Okay, how the Doppler works?
So, the basis of Doppler is that it differentiates between the flow of blood or fluid towards the probe or away from the probe. If there is flow of fluid or towards the probe, then that would appear as blue or violet on the Doppler ultrasound. If there is flow away, then that would appear as red on the ultrasound. So this way, it is able to assess the blood flow to a particular structure. In this case, the testis, and it can also assess the blood flow within the testicular tissue, apart from the main artery itself. Additionally, it can also tell us about the resistive index in some cases, which is very helpful in the kidneys, not so much in the testis.
So what is resistive index?
The resistive index is calculated as end systolic velocity minus end diastolic velocity divided by the end systolic velocity. So what this essentially means is that normally, even during diastole, there should be good blood flow in a particular tissue, and if that goes down, then the resistive index will go up. So if the end diastolic velocity is again, depends on the tissue. For instance, in the penis, end diastolic resistive index of less than 0.7 is normal. So what this means is that if end diastolic velocity is less than 70% of the systolic velocity, then that is an abnormal result, and that means that the blood flow is not sufficient to that particular tissue in the diastolic phase.
Okay, so are you able to see the pictures shared?
Yes, I can see.
Okay, what are you seeing there?
So now I can see that there are two testicles.
Okay, the one on your right side is the left testis, and one on the left side is the right testis. Okay.
So now the left testis appears hypoechoic compared to the right testis. But apart from that, I cannot see any abnormal structures on either side. On the right side, I think I can see the epididymis on the inferior aspect of the image, but on the left side, I cannot make that out very clearly. I would still like to review all the images before I make a diagnosis here, and I would also like to review the Doppler images.
Okay, so this is the Doppler.
So on the Doppler images, on the right testis, I can see normal blood flow. But on the left side, I do not see any color on the Doppler, which means that the blood flow there's no blood flow to the left testis. Combining this with the fact that it is hypoechoic, we can make a diagnosis that it is a dead testis now and is likely to atrophy from here on.
Okay, so
Yeah,
this is the transverse image, again, left testis, nothing specific finding to discuss. And longitudinal image, again, nothing specific. There is some engorgement in the epididymis.
Yes.
Yeah, that's the overall picture. So how are you going to explain this finding to the patient?
So I will discuss this finding with the patient. He's 21 years of age. I will confirm this, but it is quite likely that he's not had his family complete yet. I will explain to him that he's got a dead left testis, and ideally I would offer to do a left orchidectomy along with a right orchidopexy for him, I will explain to him that this is required for two reasons. First, I would not like to leave a dead testis inside as it can lead to anti-sperm antibodies and lead to infertility or subfertility. Additionally, he may go on to develop torsion on the right side, so the right testis would need to be fixed. I would offer him a prosthesis, but not at the same sitting, because there is a possibility of erosion and infection when we will be removing the dead testis from the left side.
Okay, how soon you need to plan the surgery?
So I would like to plan this on an elective basis. It doesn't have to be done on the same night. Ideally, I would put this through the MDT, primarily because this involves, because we need to look into where the delay happened and why this patient ended up with a dead testis, and that needs to be put on the record of the trust as well. This may have to be sent to the clinical, to the governance lead of my department. But I would like to do this procedure electively, preferably within the next week or the next 2 weeks.
Okay, so what will be your consent?
So I will, I will explain to the patient that we'll be doing a left-sided orchidectomy along with a right-sided orchidopexy. I will explain to him that we will be fixing a prosthesis at a later date if he chooses to have one. Prior to doing this, I will explain to him the possible complications, which would be intraoperative and postoperative. Intraoperative complications would include anesthesia-related complications such as cardiovascular events, respiratory events, DVT, and pulmonary embolism. I will explain intraoperative events such as possibility of bleeding requiring blood transfusion, although no, I won't be saying that, and that's very unlikely. I will
stop there.
Explain the
We'll stop there. It's 10 minutes now.
Sorry.
Okay, good.
Yes.
Good performance. How do you think you did?
I think I did okay. I sort of spoke a lot about the clinical stuff initially because this was a Uro Radiology station, but I didn't sort of find a way to go to radiology because, I mean, this was looking like a torsion when he came in.
Okay, good.
So there I think I wasted 3 minutes to 2 minutes.
Okay, overall good presentation, and usually the Uro Radiology means they won't just discuss the radiology. They will always start it as a clinical scenario. So obviously you need to spend a minute or two without missing any vital things and take it forward. My view are this patient presented quite acutely to you, number one, and there is no history like more than 24 hours pain, etc. Number two is it is nice to arrange an ultrasound quickly if there is a doubt of non-torsion possibilities. If it is a torsion possibilities, obviously you will take him to theatre, which you obviously expressed correctly. But since the urine showed possibility of infection, it is better to arrange a scan as soon as possible so that we know what's happening.
Yes.
And there is always a question if you arrange a scan and if there is absence of blood flow in one of the testes, and that is the symptomatic side, and the duration of symptoms are like 4 hours, 6 hours in that region, it's always nice to take the patient to exploration immediately, because there is a rare possibility that it is a definite torsion, absence of blood flow, but intraoperatively you can detort and you may preserve the testis. It may have happened in your hands also. So if the duration is less, even though there is no blood supply, there is a role for taking the patient to the theatre. Okay?
Got
and
it.
Two other things or three other things are, number one, you need to say that my ultrasound will depend only upon the availability. If there is if the ultrasound is going to cause a delay, I will try to explore it. That's number one. Then number two, there is no role for MDT. MDT all over the UK, the usual idea is it's like an oncology MDT. I think the better word which you are searching for is we need to discuss this in morbidity, mortality.
Morbidity, yes.
There is no role for clinical governance. There is no role for MDT. You can say there are role for like benign MDT, but we won't achieve anything. But the correct word I think you are searching is morbidity and mortality meeting, so that we will learn some findings from that. Then one question I thought of asking, but the 10 minutes elapsed, is which side you are going to operate first. So in the acute sitting, when you are operating, your site of interest is the site of symptoms. So you will be opening the scrotum. I prefer a transverse incision, but midline raphe incision is not a bad choice. So examine the affected testes first. If it is torted, try to detort, warm saline, ask the anesthetist to give 100% oxygen or whatever the best oxygen possible, and see how much you can salvage it. If you are able to salvage it, then try to do a 3-point fixation and do the 3-point fixation for the opposite side, that is the normal side, right side. But say the patient presents quite late, like 4 days history of pain, and then you know the testis is dead, you are definitely going to take the patient testis out. The scan shows a kind of a liquefaction on the left testis with some abscess-like picture, post torsion, ischemic necrosis, something like that is the ultrasound report. Then you will prefer to do the right side first, because right side is a clean side. Left side could be infected due to the ischemia, etc. So you can fix the right side first, and then you can explore the left side, and then obviously patient will end up in orchiectomy. As you said correctly, there is no role for immediate prosthesis placement. Prosthesis can wait. It's more for cosmetic reasons, and if there is any slight suspicion for infection, we need to hold on with prosthesis. Okay? Good. Anything you want to ask before sign off?
Actually, I didn't catch the duration of pain. So is it okay to ask the examiners that what is the duration of pain?
Yeah, definitely you can ask. And in fact, all the tables will have a paper and a pencil on the top. So whenever examiner is giving you the history, age, side, and duration of symptoms, if it is a stone table means the size of the stone, please make a note of it, like PSA value and those things that will help you to refer. And if there is a chance for you to draw, even if the examiner is not asking, try to draw. If there is a chance to discuss like pathway for PDFA inhibitors or something like that, try to draw, try to be very expressive with the papers also, of course, without making a mistake.
Okay, got it. Got it, Mr. Dancer.
Very good.
Yeah, thanks, Mr. Dancer.
Good. Thank you for joining.
Yeah, bye.
Okay, you are sitting in a clinic. You got 23-year-old female patient presenting with left-sided loin pain. She has this pain for a very long time, even from the age of childhood. How are you going to evaluate her loin pain?
So I will ask about the duration of the pain. It's from this long time. Then I will ask any related symptoms, like if it's related to increased intake of alcohol, or it is associated with infective systems like pyelonephritis, UTIs, or other symptoms. And then I will also ask the impact of the pain on the life and severity, and any exaggerated or relieving symptoms. And after that, I will take the other history, comorbidities, any antenatal or postnatal significant histories, any medications or any treatment for this or investigation for this pain. And then I will move on to the examination. And examination, I will do the general physical examination and then the focus examination of that kidney areas. On the left, palpate the kidney, and on the right, and then palpate the suprapubic area. And after that, I will move on to the investigations, will be with the urine dip, blood pressure, and then I will organize the ultrasound scan depending on my findings.
Okay.
And then, of course, blood baseline.
Okay, examination is normal, nothing significant. Ultrasound showed left-sided hydronephrosis. Right kidney is normal, bladder is empty. What further investigations you wish to do?
So, if the ultrasound scan is normal and I cannot see the ureter on this, it could be most likely it's the PUJ obstruction. Then my next investigation will be the MAG3 Renogram and the CT urogram.
Okay. What is MAG3 Renogram? How it works?
So MAG3 is called mercaptoacetyl triglycine acetic acid, in which the radioactive is attached with the technetium-99 is attached to the metabolite, and it is given intravenously, and then it is excreted through the kidney, and then we will take the pictures. Basically, it is a dynamic scan. It has the uptake phase and excretion phase, in which the pictures are taken after giving the metabolite. First minute every 2 seconds, and then every 2 minutes, next 20 to 30 minutes, and they are recorded on the gamma cameras, which is placed posteriorly or patient lie flat, and then plots are recorded on the computer, and then they are read.
Okay, so how are you going to interpret the results, how it is plotted?
The interpreted the rate first when we giving the scan the radioactive dye, then it is we marked on the computer the area of interest, and then the curves are taken, which with the first phase is the uptake phase, and then after the excretion phase, after the giving the furosemide. And then the furosemide is given at depending upon the requirement. Like if the child, we can at the same time when we give the dye, which is called the zero furosemide, or minus F15 or plus F20.
Okay. What is that area of interest? What do you mean by that?
The area of interest is which is marked on the both of the kidney, which shows the uptake of that tracer into the kidneys.
Okay. Why do you want to give the furosemide? What is the use of it?
The furosemide is given to give the maximum diuretic load to the kidneys, and then it tells us about the obstruction or the equivocal finding or the delayed decompensations.
Okay, so what time you are planning to give furosemide?
It depending upon the side, but if I'm usually the protocol is like we did give the 15 minutes before furosemide before the radioactive material, because it gives the maximum exhaustion of the pelvic junction, the diuresis during the study.
Okay,
so and it also and also differentiate between the equivocal findings.
Okay. You got the MAG3 Renogram results, which showed accumulation of contrast on the left side with a sluggish drainage, and left side function is 32% and right side is 68%. How are you going to explain these findings to her?
I will tell her that due to the chronic PUJ obstructions, and there is a damage to the kidney, but still it is a viable kidney, and we can have to further proceed depending on this, and say that she need some sort of surgical intervention to unblock the obstruction of the PUJ, which could be the pyeloplasty.
Any other investigations you want to do before surgery?
I indicated before I will ask for the CT urogram. I asked earlier in that.
Yeah, why CT urogram? What is the extra information you may get?
Tell us about is there any aberrant renal vessel which is crossing a lower pole and pressing over the ureter, and will also give the other relevant anatomies of the kidneys.
What relevant anatomy is useful from CT urogram?
From CT urograms, it will tell us number is there any concurrent pathology like stones or the stricture in the ureters, and also it gives the vessel renal artery anatomy as well, which help during the poroperative.
Okay, so you can see sometimes crossing vessels, and you can see the amount of hydronephrosis, and is there any role for not only dismembered pyeloplasty and also reduction pyeloplasty if you want to refashion your extra renal pelvis? Those things you can plan with the help of a CT urogram. What is the radiation dose for a MAG3 renogram?
MAG3 radiation dose ranges between 0.8 to 1 millisieverts.
What is 1 millisievert?
1 millisievert, it is the dose of the X-rays, which is have got the stochastic effects.
Okay.
Sorry, deterministic effects.
Okay. Do you know what is the normal background radiation?
It is 2 to 3 millisieverts per year.
Okay. Any other radioisotope studies used in urology?
Yeah, the other radioisotopes, these are the dimercaptosuccinic acid DMS scan to rule out the which is more for the in the to see the function of the kidney split perspective, like in the scarring and especially in the non-functional kidneys. And then other are the bone scan, which is the methyl bisphosphonate scan, and also the PET scan, also which are used nowadays.
Okay, so what do you mean? PET scan is also using radioisotope, isn't it?
Yeah, it is because in this case we use it is the positron emission tomography, in which the photon they still they still give the gamma rays.
Okay. What do you mean by tracer?
The tracer is it is the technetium-99, which is attached to the active metabolites, and active metabolites which give the function of the any organ which we need to discuss to evaluate, and then tracer is attached there, and then it emits the radiation in the gamma rays in the area of interest.
Okay, so technetium-99 is used as a tracer in which radioactive examinations?
The technetium-99 is used in like a MAG3 Renogram and then the DMS scan, and also in the bone scan.
Okay. What is the main difference between DMS scan and MAG3 when you are evaluating split function of the kidneys?
So the MAG3 is a dynamic scan, while the DMS scan is a static scan. But the dynamics are different, because the DMS scan is also it's uptake by the peritubular tissue in the kidney, while the MAG3 it is excreted by the tubules and 10% through the filtration.
Okay, that's good. It's almost time. We will complete now. That's very good. How do you think you did?
little bit haphazard, little bit, but yeah.
No, I think the theory knowledge is good. Just you need to be little bit careful again that this is a Uro Radiology table.
The voice is not clear. Hello? Yeah.
Yeah, can you hear me now? Yeah. So
okay,
you need to be a little bit clear that this is a Uro Radiology table, and the marks are heavily dependent upon how much of radiology techniques you bring in. I'm glad that you are able to get into the MAG3 Renogram and CT urogram directly for a patient with possible pelvic junction obstruction. Some small terminology changes. You said area of interest. It is not area of interest, it is ROI. What is ROI stands for?
Region of interest. Actually.
Yeah, it's region of interest. The same region of interest is also used even for CT scans and any areas, also any other investigations also. And you should be quite succinct in the difference between the MAG3 and the DMSA. Why DMSA is slightly better and accurate in giving us the split renal function compared to MAG3. But MAG3 is very good for getting the functional outcome. And when you are ordering CT urogram, there are some surgeons who don't even order CT urogram and go ahead for pyeloplasty with MAG3 alone, especially in pediatric population, because there is no other possibilities in pediatrics. But in adult, there is nothing wrong in doing a CT urogram. It will also give you a functional anatomy about the pelvis and rare possibility of stones, etc. Very good. Good performance. Any questions you want to ask before we complete for you?
No, it's okay. Thank you very much. And